Darnell is the market president for Florida Blue and a wonderful sponsor of our summit this year. He is also going to be moderating our first responder panel. I'll tell you a little bit about Darnell. He probably needs no introduction because he is well known in our region, in our state, and nationally. In his role at Florida Blue, he's responsible for Florida Blue's financial and market growth, customer experience, and community engagement across North Florida counties, covering cities from St. Augustine to Pensacola. Darnell is a recognized leader in our community. He sits on countless boards. We've been begging him to be on our board as well. He's so busy. Some of the boards are Jacksonville Chamber of Commerce, Economic Development Council of Tallahassee, JAX USA Policy Council, Big Bend Minority Chamber of Commerce, Sulzbacher Center, and Lift JAX. I'm so grateful to work with Darnell on many incredible, innovative Florida Blue initiatives, and I'm very, very privileged to call you my friend. We're so pleased to welcome you again. Darnell moderated a panel in last year's summit, and I'm going to introduce and have Darnell come up now, and he's going to introduce the panel. So without further ado, my friend Darnell. Thank
you. All right. How do you follow that last presentation? Well, you follow it with 6 amazing individuals who are going to get a chance to talk to us about what they do to help change lives as well. We had a chance to see the video, and you got a glimpse of just how difficult it is for many of our first responders. Many of them, they leave a 911 call, but often the 911 call doesn't leave them. They deal with trauma and stressors every day. And imagine dealing with those traumas and those stressors for many, many years. And so these wonderful individuals who I'll begin to introduce, because they're going to be the ones to give you a glimpse into what the lives of our first responders are and the families as well, and help us understand what we can do to be able to really help these first responders. I'll start with Dr. Kelly O'Dare, to my immediate left. She is an assistant professor of health policy and management with the Institute of Public Health at Florida A&M University and the founder and executive director of the Second Alarm Project, which is also one of the 5 state grantees. She has worked with dozens of Florida-based agencies in support of first responders and has conducted mental health training with hundreds of first responders, family members, and leadership teams. She is the niece of a first responder, lost in the line of duty in Miami-Dade County, and the wife of a first responder. Please welcome Dr. Kelly O'Dare. And then I'm going to go to Meg Ross, First Responder Ambassador, Crisis Center of Tampa Bay, one of the 5 state grantees as well for the First Responder Peer Support Grant. She completed a 33-year career with the University of South Florida Police Department in 2021. She rose from a patrol officer to acting assistant chief overseeing all areas of the agency. Meg has the distinction of being the highest ranking female in the history of the agency. She has returned to the workforce as the First Responder Ambassador, representing the First Responder Hope Line. Meg is the wife of a retired first responder, law enforcement officer, who also served for more than 30 years. Welcome, my friend. I'm going to go over to Luis Lopez. Director, Southeast Florida First Responder Support Coalition, also one of the 5 state grantees. He has more than 20 years of experience in law enforcement, criminal justice education, and crisis response in his role as Director of Peer Support Services for 211 Broward. He oversees the daily operations of the helpline serving first responders. Luis runs a successful criminal case consulting and investigative firm, is a certified drug recognition expert instructor, and a veteran professor in academia. Luis is a passionate advocate for mental health and suicide prevention. Welcome, Luis. Dr. Tracy Hejmanowski, founder and CEO, First Responder Project, a nonprofit that provides retreats for operators and their loved ones. Tracy has 2 decades of clinical expertise working with service members, veterans, first responders, and their families. A former Lieutenant Commander, Navy clinical psychologist, Tracy served for 11 years as the primary clinician and program manager at Jacksonville Naval Hospital Deployment Health Center. Tracy regularly provides seminars and briefs on operational trauma for conventional and special forces, public safety communities, and their families. Welcome, Tracy. Brandon Hicks, retired law enforcement officer who has trained first responders all over the country, a suicide survivor having lost his child to suicide. One of Brandon's goals include keeping names off the law enforcement memorial in D.C. He believes his own recovery is strengthened by helping others. Brandon is a first responder peer. Here tomorrow, also one of the peer support programs from LSF. And I look forward to learning a lot about you. Loved your bio. I had to look you up. And very, very interesting story, my friend. Welcome, Brandon. Lastly, but not least, Dr. David Rosette, clinical psychologist and associate professor at the University of Texas Health Science Center at San Antonio. See, I did my work, my friend. Prior to his current position, Dr. Rosette was professor at the University of Central Florida and served as the director of the National Center of Excellence for First Responder Behavioral Health at UCF Restores, also one of the 5 state grantees. His research and clinical expertise are in cognitive and behavioral therapies for suicide, depression, and PTSD. Welcome, David. I'll begin with our first responder peers. Just a couple of questions, and you guys can chime in as you like. What are some of the biggest challenges that first responders face in regard to mental health and well-being? And as you answer that question, I want you to also speak to whether or not there are generational components of that, retirees, et cetera. Love to hear your thoughts.
Well, the big one is stigma. I think we would all say that. And as far as generational, I do think that there's good news. I think that the younger generations are not as stigmatized as to seeking mental health resources. So I think when some of these dinosaurs like me leave the profession, we may see an improvement in some of that.
Sure thing. Good morning, everyone. So we hear a lot about stigma. So I want to identify that real quick in this community. The first responder community is a very different community. They go through a lot. What they go through every single day. It's on the street. Everybody thinks it's the calls, but there's a lot more to it. It's what's happening in the departments, bureaucracy, everything else that takes a big toll with them. So I want to talk a little bit about stigma real quick if I can have 2 minutes for it. Because in mental health, we always think about that, and I hear it in every facet. And when you look at first responders, you think, well, what does that mean? Does that mean bravado? Does that mean they don't want their friends to know they need help? And it's a lot deeper than that. The stigma in first responders is more along the lines of they're scared. They're scared because if they come forward, they're going to be investigated. They're going to find reasons to get them off the force. And if this is 90% for law enforcement, it might be 70% for fire department. Like, it's different for different first responder communities. But I can tell you from the law enforcement perspective, if something's wrong with you, they don't come talk to you, they investigate you. It's a very different world. So when you see stigma, it's not just they just don't want to get help, or they think they're better, or they're arrogant. It's not like that at all. It's honestly, it's a fear. It's a fear that if they come forward, if somebody finds out, are they going to lose their gun? Are they going to lose their job? And this is a career where, depending how you leave, you might not be able to work anywhere else. So it's a very terrifying place. And that's why a lot of people do not want to get help. It's because of that.
Now, when you say if they leave, they may not be able to work somewhere else.
Correct. Like, for instance, Florida, we have to get a certificate from the academy. You go to the academy and you're certified as a police officer. Once you get investigated, if you lose that certificate, you can't work anywhere else. Or if you get labeled on the way out, where when you leave the department itself, you're leaving under investigation. Nobody else will hire you. You're done as a first responder, and that, at least in that career sector. So that's where, when we say stigma, I'm like, I got to talk a little bit about stigma, because it's not what everybody thinks. There's a lot more to it, and there's an embedded fear in it.
That's powerful, Luis. Thank you.
Thank you. Yeah, I agree with Meg. I think that generationally there's a big change. This next generation is much more open, and they're coming into the profession with a better sense of where their mental health is at and how to address it. I agree as well. I think when we think of stigma as it affects the general population, it's not stigma as it affects first responders. We have very different concerns. And any first responder I talk to still, one of their first concerns is fitness for duty. Scary words, when you're a first responder, because if that is questioned, it affects not only your career trajectory, but it might affect what you can do after you leave your role as a first responder. I would also say I don't think we're even scratching the surface on understanding the problem yet, and I'll give you this as an example. We know that we lose 22 veterans a day to suicide. We know that because we have a VA. We have a Department of Veterans Affairs. We have no such thing for first responders. So if a young woman comes into a career as a first responder and she serves for 2, 3, 4, 5 years and then separates, and then because of what she's experienced in her service, we lose her to suicide, we don't know that. We have no way of tracking them. We have really no official way of getting them help. So I think we're just starting to understand how this problem really forms and the scope of it. Because if you tell me that we lose 140 or 150 first responders every year to suicide, I have to question that. I don't think we have any idea how many we lose, because we don't have a system in place to track it and catalog it.
I would add to that we do know, and I think it's important for the audience to know, that we lose more first responders to suicide than are killed in the line of duty. But we don't put mental health commensurate with other training. So we have gear and training and equipment and all these things to make people safe, but they're still in the culture of first responder agencies and departments. It's still not at the level, even though statistically we know that it makes the most sense. And I think another aspect of stigma, or at least reluctance to seek care, is two other things that people don't necessarily know what's wrong with them. They know they're trapped under something heavy, but they can't identify what it is. So it's not this compelling one incident or one acute event that's happening. It's more the accumulation of that. And also, I've heard, many times clinically, what's the point? I'm just going to go right back into it. So, I'll sleep when I'm dead, sort of thing. Like many of us who move and shake will say. So I'll take care of that, after I retire. I'll take care of that when I absolutely have to. Right, but no one plans their DUI, no one plans their domestic, no one plans those bad outcomes. So I think that's a piece of it from the clinical side of it.
So Tracy, since you have the mic, and I'd love to, for all of you to get a chance to speak to this as well. Speak to some of those unique occupational stressors that our first responders experience, and not only the first responders, but as a result of them experiencing it, what the families have to experience as well.
So I'll speak as a clinician, but I definitely don't want to take time away from first responders. The way I see it, I think that there is a trifecta of trauma. I think there's exposure to tragedy, threat, and transgression. And there can be a combination thereof of those things. And that's one thing I try to help people understand, is to kind of categorize the types of exposure. You can respond to a call and have it hit all those markers at the same time. And you're responding as a professional, but your human is responding as well. So if there's a child death, you may be responding as a parent, or if there's something else domestic and you have that in your history of being exposed to that. So the human being is always watching. It's sort of like in the back. And I think as professionals, we want to push that aside. And but it's important to recognize that, because those things accumulate, but they're also very complex, because you're not only seeing it and witnessing it, but you may be receiving trauma and you may be participating in it, which is something unique to first responders and military, for that matter, that you can participate in your own trauma if you're an officer-involved shooting, or you're rendering CPR and it's I don't want to say ineffective, but maybe there's no capacity for it to be affected. So I think it can be really complex just in one call on one shift in 1 hour, let alone the continuum of a career. And for family members, I think that it's a very kind thing to do, and maybe self-preservation, that first responders push their families, or kind of keep them on the outside of that. One, maybe because they don't want to share the information and put those images in their loved one's mind. Part of it is just not being able to put words to trauma. That our lexicon sort of stops where trauma begins. And part of it may be also that they don't want to open up the door to having to talk about their feelings. But nevertheless, families are stonewalled and stiff-armed, and so they don't really know. They know, and it's not so much what's wrong with you, but it's a matter of what's happened to you, or what you've been exposed or happened to other people. So families are often on the outside looking in, and they know there's profound change in their loved one, but they just don't have the data and the input to be able to help.
I'll say, to address what's different, what's kind of unique about the what first responders go through. I work in a beach community. It's a beautiful community, and people drive around that community and think, oh, the beach is so nice. Well, that's where my friend got shot. This hotel, man, it's a lovely hotel. Yeah, that's where I found a sexual assault victim and had to help her. This neighborhood's really come up. This is where I held a dead infant in my hands trying to revive it. So when we travel around the communities that we have worked in and that we see every day, when it looks like something to someone who has not been in that position, we see something very different. And it becomes difficult to participate in a reality that we see very differently. When people are having fun in these communities, when they're experiencing joy, when they're doing all of these things, these are often emotional states that we can't really access because of the trauma that we've experienced in them. So we move around the world in a very different way.
Awesome.
So what's unique to first responders? And I come from a law enforcement background, so I'll speak specifically to that. And I'll give some of my own stories. I was fortunate enough to work on both sides of Florida. I ended my career up in Jacksonville, and I worked in Miami for over 10 years before that. And I worked from MODEG to Gang Task Force, which was the funnest time. Early in my career, to traffic homicide, to you can obviously know what I see every single day. Every time I got called out, it wasn't because somebody was slightly hurt; it was a bad deal. Dealt with all that, but I'll tell you, those weren't the ones that really hit me. And I worked in Jacksonville, where you just saw shooting after shooting, and it was okay. It was like people tell you sign up for it, right? This is what you sign up for, just deal with it. And it wasn't those. It was when I had two babies that I did CPR on. One I lost, the other one I was able to get back. And I can remember this clear as day, and this is early on in my career. I have probably been an officer for 2 years. Get to the house, the baby's still under the water. This is an area with a very affluent community. So there's always nannies and stuff. Nannies literally still holding the baby under the water. So just freaked out, couldn't let go of it. So I had to push her, get the baby out, do what I need to do. I escorted rescue to the hospital, did CPR before they got there, all that good stuff, right? I am now wet. I'm at the hospital, and I'm waiting because I want to know what happened, an outcome. I start getting screamed at because I haven't cleared for another call. And I'm like, in a very nasty way, I explained back why I'm still there, because I couldn't believe I had to explain it back. but like those were the things that hit. Or I'm at a really bad traffic homicide scene, and they're like, "Hey, when are you opening up the roads?" Well, we're going to be here for a couple hours. I got a lot of things I got to do. We got to get the roads open. People have to travel. Like, you know what I just dealt with? We want to talk about this. And then, like I said, there's another side to this, and this is where the uniqueness comes in. Is the investigator? Sorry, I don't like microphones. I try to talk loud so I don't have to. So the investigatory side, and I can tell you firsthand, I ended my career working in internal affairs, not by choice. I was voluntold to go there. Let me tell you, worst job I ever did. Learned the most, and that's where I learned the pain that is brought on first responders. Because everybody's heard about the brotherhood, right? And we all work together. Let me tell you how it works. When you get in trouble, nobody talks to you. There's no help for you. Nobody in the department can do anything for you. And you're literally told by law, don't talk to anybody about it. So you saw these people that are in incredible pain, and you're like, who helps them? You know, so I'm literally there as the investigator trying to give them guidance. So like, hey, before we talk, you might want to go get some help or something else. And I'm like, this is incredible. What happened to everything I was promised? I was promised this brotherhood and everything else. And here's this person crying. And they can't talk to anybody. And nobody wants to talk to them. So that's the uniqueness here. And that's why as clinicians, when they come to you for help, they come from a very different aspect. Basically, everything I've said, everything you've heard here so far, and you will continue hearing, put it all together, and that's why they act so weird.
Wow.
Yeah, I have to agree with the IA and the isolation that you feel. I also have experience on both sides. So I am a first responder, and I have some of the traumas that you experience there, but also the family member, the spouse of a first responder. I like to say that my experience was the frequency of critical incidents and traumas was much lower than what my husband experienced. So I was at home imagining what my husband is experiencing when he's on his calls, and so I have that experience as a family of a first responder. I also knew enough, so he did share with me, and that is something that many don't do, but I knew enough to be concerned about what was going on because I knew what was going on. I knew he was hunting down someone who had gotten into a shooting with one of my officers, and that he was out all night laying in the dirt outside of a house waiting for him to come out, ready to fire if he should come out. So those are the stressors that, and many spouses would know that too, maybe not to the degree that I would. It also comes at different levels at different times, and someone spoke about babies well, I wasn't a parent for my first 15 years as a first responder. So I had my daughter in 2003, and it's a different experience. It's the greatest thing in the world to have children. But when you start to recognize that the person, when you start to be a mother, when you're responding to these calls, when you are dealing with a traffic crash involving a pedestrian, and it could be your daughter. And my husband experienced that as well. I'm talking about a time when he was searching for a missing child that he knew he was not going to find alive. And he's telling me, which he was sharing with me, it was wonderful that he was able to share that to kind of release some of the trauma exposure. But all he saw when he looked at the picture for this girl was our daughter. So those are some of the kind of unimaginable traumas that first responders experience and may show up much later. So, maybe I can go back my first year and all of a sudden, now that I'm a parent, that vision is coming back into my mind. So the triggers are.
And so, Meg, the fact that, you're the wife of a law enforcement officer, did that help in the overall conversations, daily conversations?
I think it did. We still talk today about the traumas, and I think it's because we did, and we both say that we were successful because we were our own, we talked things through, and that really was a huge support. But, most first responders have divorce in their background because they're not able to do that. And this is my first marriage, but it is not my husband's, so he already experienced a divorce as well. So,
wow. I understand that all of you guys are working through programs and that you have to help first responders, but I also understand that there's some innovative programs that you guys are working on, and I understand Dr. O'Dare as well as Dr. Rozek that you guys are going to speak to a couple of those, if you don't mind. I don't know. I think there's a clicker here available. I don't know if it was. Nope. Okay.
I think Dr. Rozek has the clicker.
Okay. There he is. He has the clicker.
Yeah, so we have some really kind of innovative and interesting programs that, is that better? There we go. So at UCF Restores, we've developed some really interesting programs and innovative programs. And I just want to give a little bit of background because we've all talked about it up here so far, but PTSD and these different traumas that happen elicit a lot of fear responses. We know that. We know that there's a lot of fear that comes with the job in the first responder world. And so when we think about how do we help someone after a trauma, if it's partly fear-based, we have to get them exposed to what that fear is again to show them that they can manage that. And so I'm going to use an example of a dog. I'm sitting next to a very friendly dog here. But if you're afraid of dogs, the way to get you over that fear of dogs is we can't avoid dogs forever. We have to get you exposed to those dogs. And you'll start to see that you can manage that. For me, it's spiders. Like, spiders do it for me. I can't do it. But if I wanted to get over that fear, which I'm not sure I do, I would expose myself to those spiders. We know this works really well. Now, we want to do this with trained professionals. We want to do this in a systematic way. And so that's what we've been doing at UCF Restores. But some of these traumas we can't expose you to. We can't expose you to those different scenes. And so what we've done is we've started using virtual reality to do this. And so we've created a system, and I'll show you an example here, that is really easy to use. And the reason we did this is we wanted to make it available for clinicians all across everywhere. So this does not take an IT degree to use. I can use it. I know Dr. Lloyd talked how he can't use his phone. I feel like I at one point was really good at technology. Now I feel old. I can use this machine. We can create a lot of different customized scenes. So up here on the screen, what you'll see is one of the tragedies that we responded to, and I know Dr. O'Dare was there as well, was the Surfside building collapse. So we've seen a lot of first responders, as well as people who were in that community, who have developed PTSD. To expose them to that scenario is really hard, right? We can't go out into the community and find a building like that or a scene like that, but we can use virtual reality to help them overcome the symptoms, that fear. And so we've done that. I'm going to show you a video of the actual VR system. Now, every scene is tailored to the person. So different people at Surfside, for example, we're on different parts of the pile. We're doing different jobs. We can tailor all of that. So let me walk you through here. So this is one scene where someone who was working on the pile, and this was used in treatment, and you can see we can have them walk through different areas. We can see the crane in the background. We can see different parts of the rubble. Now, what we're doing with the individual as they're walking through this virtually is they're narrating their story. We're giving them power and control back over their narrative while providing the visuals. We want them to have some of that fear response, those negative emotions. We want them to walk through that because what we see as they go through it, they're able to regain that control. And this isn't a simple one session. I'll tell you a little bit about our data, but we can put so much detail into this. We've actually used things like smells. So if you think about some of your worst memories or even happiest memories, we can trigger that with smells. So we can do the same thing with virtual reality and adding smells into that. Now, we've done this with a lot of different scenes. We have one, for example, we also have the Pulse nightclub that we've treated a lot of people with. We've used this for different scenarios like sexual assault and rape, and thinking about when that happened, designing things like hotel rooms, bar situations. We can create all of these customized scenes to really help these people get over kind of the impact of the trauma. Now, we don't erase the trauma. I want to be very clear. That is something that sticks with people, but we can help reduce the symptoms and help them recover from what happened. Now, I'm a nerd, so I have to show the data. I do want to say that we have done a clinical trial on this using the virtual reality. It was all first responders in our sample, and we actually did an intensive 2-week treatment. So if you think about regular mental health treatment, 1 session a week, how great is that for first responders who do shift work and have to do overtime? Do you think they can make that stable 1 session a week? They can't. It's really tough. And so we condense treatment to do it daily for 2 weeks. So if you think about a time where someone has a broken leg, if they need to take 2 weeks off for work to help that recover or to get surgery, we don't bat an eye at that. But if someone has a trauma or a mental health issue, we say, oh, just go weekly and it's fine. So we said, why? Let's do 2 weeks. We can do this. We've done a 2-week and a 3-week program. We found that 2 weeks works just as well. But let me show you the data. What we see here is, and you don't have to read the graph, I promise, the big bars are pre-treatment, the little bars are post-treatment. So people came in with PTSD, came in with high symptoms of PTSD and depression. They left without those symptoms or a lot lower symptoms. 100% of the people who went through this program, all of our first responders, left without a diagnosis of PTSD. It's huge in 2 weeks. And we have follow-up data. So the clinical trial was an initial pilot sample, and then we've treated over 500 first responders. Yep. So, and we're adding in the VR for people that it works for, because if you get motion sickness, we have to be careful. But we use the same exposure therapy and see very similar results, and they hold. So we have follow-up data. We have in our program about a 1% remission rate.
That's amazing. That is amazing. Congratulations, my friend. Dr. Adair.
Thank you. So I started in this work approximately 10 years ago when I was a faculty member at a different university over in the far most west part of the state of Florida. And at that time, my husband was working for a fire department there, and the chief of that fire department came to my academic organization and said, hey, do y'all happen to know anything about this PTSD stuff? We're starting to hear a lot more about this PTSD stuff. And we said at that time, well, we know an awful lot about PTSD, but we don't really know much about PTSD with first responders at all. This was kind of still the dark ages of doing this work with first responders 10 years ago. And so we started doing research. As an academician, that's what we do, is we do research. So we went in and we started measuring the prevalence of things like PTSD and suicidal thoughts and depression, anxiety, harmful substance use with first responders. And what we found was pretty astounding. We found incredibly high prevalence rates across the board of all of those issues in our first responder population. So we'd take that research back to the organization, back to the chief, and we'd say, Chief, here you go. Here's what's going on in your organization. 30% of your men and women would screen in for PTSD. 15% are at high risk for suicide. And so after a while of doing that, I got real tired of bringing them a lot of problems without a lot of solutions. So in 2019, after Hurricane Michael came through the Panhandle, we were able to get our first federal grant to start doing some work with first responders and to start creating solutions for some of these problems. So that way, the next time I was in a chief's office, I didn't just bring him or her a problem. I also brought with it a set of solutions. So at that time, we set out to learn who was doing this in the business already in the state and who was doing it well. And of course, found many of our colleagues up here on the panel, specifically UCF Restores and a couple of other organizations. And we really tried to partner with those organizations to learn about evidence-based best practices. And one that's been talked about a lot this morning, not just on this panel, but in the presentation before, was peer support. And I believe we're going to talk about that in a little bit more here, but just the importance of peer support. Another thing that we do that is very important is the organizational level and cultural change level. As you've heard us talking about how important it is to change the culture, not just for that individual first responder who might be experiencing some internalized stigma, but also for first responder organizations. There really needs to be a culture shift and a policy shift, so that way when a critical incident occurs, the chief isn't yelling at you, asking you why you haven't cleared to get on your next call, because that chief now understands that you have a human brain and a human body, and you need some time to be able to decompress after that. And so I will say one of the innovative and fun things that we've been able to do lately is to deploy to some of these larger disasters in the state of Florida. The first one we deployed to, as Dr. Rozek mentioned, him and his colleagues were there as well, was the Surfside building collapse, to do peer support. And we also had clinicians available for that as well, and canine peer support, which our furry friends are a big hit. Oftentimes, the first responders on these deployments are more excited to see the dogs than they are the people, which is understandable sometimes. We have also deployed after Hurricane Ian and most recently to Hurricane Idalia. So peer support is really the heart of a resilient first responder organization, and to be able to do this in a coordinated way through the state. It is now a part of the state's emergency response plan to be able to deploy these teams into these disasters.
That's amazing. Really good work, my friend.
Thank you.
Awesome. And you talked about furry friends, and Brannon brought us one. And that furry friend has just been amazing today. Talk a little bit about your furry friend there, Brannon.
Sure. I'm not an expert in training service dogs. I'm just fortunate enough to have found a good one who likes microphones, apparently. So they are often, you'll find that people with post-traumatic stress disorder often do have service dogs. They're a good way to ground yourself. She cues on me. So when I get nervous, when I get, my anxiety goes up a bit. So she starts doing things like this. And so she insists that I interact with her, and that's a good way for me to ground and just kind of make sure that I'm in the place where I intend to be. So what you see her doing is just basically kind of keying on some of my anxiety and helping me via pressure to deal with those things. So she's been a huge asset, and we are used in the first responder community to working with canines in many capacities, so we're pretty happy to see them around. And it's pretty easy to integrate canines as a grounding tool for first responders and veterans, simply because we have such a culture that's already so ingrained with them. We're used to seeing them, we're used to working with them and relying on them, and they help us out quite a bit.
That's awesome. What's her name?
Her name is Elvie, like Elvira, short for that.
Elvira, Elvie. Okay, that's awesome. I got to tell you, I got to believe when you're serving a first responder, cultural competency matters. And as I think about cultural competency, it's really more about, do you have an appreciation and understanding of what they're really going through so you can treat them appropriately? How difficult is it for individuals who do serve them or serve first responders to really, have that cultural competency, and what do we do about it? How do we make certain that more and more people who do serve first responders realize what they're going through, even if it's just a boss who could, realize that you just went through something traumatic with a baby in a pool? How do we get folks there from a cultural competency standpoint?
I'll start since I'm holding the microphone. I think a couple of people have touched on what has to happen. There needs to be a cultural change. Because we have existing a culture that tells us, be Superman. You call 911 and we come. We don't call 911. We help you, you don't help us. And that has to change. And that we're tempted often to try to do that from the top, try to talk to the sheriff, talk to the chief, and get them to adopt these programs. You may or may not be surprised to learn that many law enforcement officers in particular are suspicious, just kind of by nature. And if anything comes from the top down, it's often met with suspicion, if not outright derision. Not to say that there aren't good chiefs, sheriffs, administrators out there. There are plenty, but there is often an adversarial relationship, as you touched on, between the rank and file and the administration, or those aspects of administration which are assigned to investigate us when we are struggling. So I think that cultural shift needs to start at the bottom, and it needs to be a grassroots movement, if you will. It's a bit of an overused term, but I would like to see that start in the academy. Not on day one when you're hired, but on day one when we start training. Let everyone know that mental health struggles are a routine part of being a first responder. It doesn't make you abnormal if you are experiencing them. We have help that is there from day one, and I think we need to continue that with new hires and make it a prehabilitation kind of approach rather than a rehabilitation approach. Don't wait for something to go wrong.
I love what you're talking about there, and I know others are going to speak to that question that I just put out there. But I want to really go deep. Yes, we say we want a cultural change. Guys, how do we get there? How do we have, I'm in insurance, right? It would be an outside influence on your senior leaders in law enforcement in order to, or, any other first responder. How do we get the cultural change?
I got drafted, so I'm here. Time. Yeah, absolutely. So, time. You definitely need time. I'll start from a clinician perspective, and I'm not a clinician, so I cannot speak for something I don't know. But I'll give you a prime facet of kind of life as a first responder. Whether you're a firefighter, police officer, dispatcher, once you're released from training, you're expected to be an officer. You're expected to be an expert at whatever you do. I mean, if there's a building on fire, you're there, you're the expert. You could be 2 weeks on the job. That's what you do. With a law enforcement officer, the same thing. It's kind of ironic the way it works, because when you're released to patrol, and that's the first thing you ever start in, you have to be an expert on anything happens to you, whatever call gets in, whatever you go to, you have to be that expert. But as you are in law enforcement for 10 or 15 years, you then specialize and you go to all these training classes to do a lot less work, which is ironic how that works out. So with that said, it's like, okay, so you need to know the most when you're the youngest. Okay. I like the plan. So with that said, from the clinician perspective, treat the first responders where they're at. And what I mean by that is they're going to come in and, like he says, we're going to be suspicious, right? There's a reason for it. It's not that we don't know the system. Trust me, we know insurance. We know how to get treatment. Think about it. We're the first doctors that have to Baker Act how many people on a regular basis and deal with that whole process and deal with the whole system and intake and outtake and all that. Trust me, we know a lot about it. So when we're there and we're like, hang on, are you going to call my insurance company? It's not because I'm worried about whether you take my insurance or not. I'm worried because I might have a health trust, and the health trust is approved. I'll give you an example. One of the places I worked at, when you went to the doctor, it was approved by our FOP, by our benevolent association. So in other words, if I went to any doctor, guess who knew about it? The department. So if I go to a clinician and I'm like, I don't want to use my insurance, it's not because I just don't want to use it or I'm arrogant or something. There's a reason for it. You want to speak to my family, and I'm like, no. There might be a reason for it. I might be protecting them. We deal with a lot of bad things. Like when I was in the gang unit, it was, you didn't bring anything home. I mean, you didn't even go directly home or anything else because you were dealing with very bad people. So you're like, I can't bring this home. I had one of my sergeants, brand new baby, a brick got thrown through his window, almost hit his baby. And that was completely job related. Somebody followed him home. So there was a big deal. So when you want to touch my family, I'm like, yeah, they don't exist. That's why you can't look us up. And addresses are blocked and everything else. So just keep in mind that when you're dealing with this community, they're going to ask a lot of questions and they're going to come a little weird at you. Ask them a little bit of questions. Don't just judge, because there might be a lot of reasons of why they're acting that way, why they're asking these questions, why they're hesitant to move forward. And as far as a cultural change, even within the organization, he's absolutely right. We got to start it at the academy level, and an acceptance for it is a big deal. The fact that if you do ask and seek help, you're not going to be, you can't prevent people from judging. That's to think that it's an innocent way of thinking. That's just not going to happen. People are going to judge you. It is what it is. But if somehow you don't have to be scared for the rest of your career, or that your career will be ending because of the help you're going to need, that's a definite step in the right direction. And from insurance perspective, like you said, your insurance, one of the biggest things, and that's where the fear comes in, is that there's not a pushback where if I go to a clinician and the insurance approves it, that it doesn't get back to my department. I don't want them to know about it. Absolutely.
One of the things that we're doing, for First Responder Project, is we're providing some educational summits, and we invite clinicians to come in, because it's not just about what you're hearing today in terms of cultural competency, but it's about your personality. It's about your handshake, your eye contact. I mean, you should have an extra firm handshake. You might want to roll their wrist a little bit. You have to have direct eye contact. You have to be confident and know when to fake it, and you don't know the acronym and look it up later, or when to ask them and just say, "You're snowing me," and I think you're doing it on purpose, but that's okay. Like I'm leaning in, but it's not for everybody. Just like working with military or any other niche of mental health or behavioral health. So we try to let people know, like, these are the certain nuances and intangibles that are important about working with this population, but it'll be the most rewarding work you ever do. So we try to bring people in and do that. To the cultural change within the organizations, what we're trying to do with FRP as well is meet people where they're at, as you've said, and provide retreats. So they are therapeutic, but it is not therapy. They're run, we have about 15 hours of mental health training, so that agencies and departments can send their people on training time to reduce the fear and the stigma associated with going for help. But we also do it in a peer support capacity. So we bring in the first responder, their primary support person, their loved one who they identify, and that might be their coworker. If that's their psychological, emotional whoopee, come on in. But we make sure that everything they do together. We bring our first responders. They do some things and activities, and sometimes it's something in creative expression with mask making, where we ask them to think about access a part of their brain that is not relying heavily on verbal output, but instead getting them to figure out non-verbally how to represent their identity, and oftentimes trauma is a part of that. And it is sometimes initially seen as like, oh, we're going to do artsy craftsy stuff, and that takes about 2 minutes, and then that goes away, and then they deep dive, and then they have a chance to sit around and share that, and it becomes very emotional. And so that the retreat is really meant to be a springboard that we can talk about these things, and it doesn't have to be in mental health language. We prefer it not be. That this is the nature of the beast, the wear and tear of the job, and you're a human underneath the uniform.
I love that, Tracy. I love that.
So I just wanted to talk a little bit about the clinician side too, because the first time I heard this story, I was like, this is going to be a one-off. So we had a first responder come to UCF Restores, very hesitant to engage, and this was a law enforcement officer. No, it's okay.
Hope you're okay.
I was like, I'm married to a law enforcement officer, so I got my own trauma. No. When we think about it, though, this person came in and was asking tons of questions and wasn't sure that they could trust us. They were worried about things of like how many people are going to be in the waiting room, because it's going to be other first responders, because that's the community we serve. Are there high-ranking people that might stop by? Do you have tours that come in? And it's like all very different questions from a clinician standpoint. When we got to talking to this individual, we heard the story of, well, I went to an EAP clinician, or I went to a community clinician, and I sat down and they asked me, well, what's going on? What brought you in? And I say, well, last week I saw 3 dead babies in pools. I saw a family that was decapitated on the road. But those aren't really bothering me. It's actually the stuff at home that's bothering me. And the clinician is just like, nope. And we've had the story of the clinician starting to cry. Like, that's too much for me as a clinician to handle. When that happens to a first responder, whether it's law enforcement, whether it's fire, whether it's dispatch, whether EMS, do you think that person's coming back to any mental health provider? The answer is no, in my experience. And in therapy, the modal number of sessions is 1. So we have 1 session to try to get these individuals to come back. So some of the things that we've been doing at Restores is we've developed cultural competency courses for clinicians. And it's not just us on our side. We involve first responders and said, what should clinicians know? We have clinicians and first responders as part of the trainers in the trainings, because the idea is this is a culture that you need to be aware of. Now, you don't need to know every acronym. Sometimes if you quiz some of the first responders on what the acronyms actually mean, they may not know all of the letters. They just use the acronyms, right? We see that in military as well. But you do need to have an understanding of the culture of what's going on, when to ask those questions, when you need to learn different things, and even just how their shifts work, things like the very basic things. And so when we think of kind of the culture shift, it would be amazing if we had culture shift on the first responder side. But if we're not ready for that as clinicians, for them to seek help and be competent to work with these individuals, we're going to let them down, and we're going to shut down that culture change.
That's often awesome. Meg, you going to say something?
So I totally agree with everything everybody said. Here at the Crisis Center, we have a strategic planning group. We just completed our strategic plan for Hillsborough County. I imagine it's going to be similar for the other counties, but our plan is 4 pillars: resources, education, accessibility, and leadership. So when Brandon talks about education, yes, in the academy, but also throughout their career, and by the way, right before retirement, which is a very critical time, and somebody who did retire and expected and planned and was ready and was not ready for what I encountered sitting at home alone with nothing to do after 33 years of being involved. So our plan is Real Hope, REAL, which is the resources, education, accessibility, and leadership. Normalizing self-care within the agency. I just heard the local Tampa FBI office allows 3 hours a week for self-care. No questions asked. 3 hours out of your work week for self-care. I got to the crisis center and they really talk about self-care. I'm like, what is this? This is crazy. They let you go to yoga. I mean, this is crazy. I come from a first responder agency. That is a total culture change. Now, I'm not saying, there's a time and a place, because you can't take your gun belt off and be in yoga when the mass shooting goes out, but there has to be some acknowledgement of that. Bringing in a chaplain for your agency could do wonders, but leadership needs to be on board. They need to allow for those kinds of things. We need to educate from the start in the academy. Our resources are not enough. Thank you, Dr. Rozek. We need more culturally competent clinicians. And then leadership, accessibility, insurance. Nobody wants to use their insurance, whether it's because they don't want their spouse to know that they're struggling and they're going to a mental health, or their agency. Having had to send one of my officers when I was a brand new sergeant for a fitness for duty, it's a very difficult thing to have to ask and to actually go through. Fortunate for me, that one experience was a positive. That officer came out stronger because of accessing those services. So it's very important that we come up with this kind of a plan, whether it's the Real Hope plan or something else, for these first responder agencies to recognize that the culture changes, but in many different areas.
I love it. Now we're going to see if there are any questions from the audience. But as we do that, I want each one of you to think about what you want to share with the audience. What do you want to leave them with? The one thing that you want to make certain that they hear before they leave. Any questions from the audience?
Morning, everybody. Thank you so much for sharing. I really appreciate it. We just got the contract to provide the Building First Responder Resilience for Volusia Recovery Alliance in Volusia County. I'm blessed with the relationship that we have already established with our sheriff. I do get to do 3 hours of training about substance use disorder and recovery. We have our own academy in Volusia County. So my question is, what are some of the best tools to share about self-care with the new recruits? But also, I kind of go over what happens in the brain with substance and everything, but what are some things that we should really focus on in training? Thank you.
All right, so spending over a decade in training, I'll take a quick stab at that one first. So things that you should focus on, especially with new recruits. First of all, explain self-care, that it's okay to take time out, that this is going to be overwhelming, that they can talk to other people about it. They can talk, there's going to be help in the department. The new concepts coming around, the BHAP programs everywhere, which is basically just behavioral health access programs and all that it's available, that it's okay for them to use it. Biggest thing in training is, and this is something I came up with, I call it my vicious cycle, and it's why I feel that we fall into these problems. You start as a new recruit, and this will be pretty law enforcement specific, but I think fire goes through the same thing. You start as a new recruit, you usually either have a significant other or you get married shortly after, and you start working. At that time, they let you do off-duty jobs, right? Once you start doing the off-duty jobs, you are never home because you're making all this money, and when you get home, you're dealing with certain stuff, all this stuff on the road. You can't really talk at home with anybody. And the reason you can is, like a lot of police officers marry nurses, right? Well, my wife comes home and she's telling me all about these patients. And I'm like, do you know what I dealt with? And you get this arrogance about you where you're like, I can't talk to you. So if I'm at work more, I'm making more money. You should be happy. And I don't have to talk to anybody. And the more upset I am, the more I go to work. And that's it. It's this vicious cycle. Eventually, what happens? I start finding somebody else to hang out with more at home. That becomes my other significant other, correct? There, from there, my home life starts falling apart. There, substance abuse comes into play. And this vicious cycle just keeps repeating itself over and over. And this is something that we should talk to new recruits about, going, this is going to happen. All these opportunities, this is the way it's going to kind of go. And you got to meter yourself from the beginning. The more you make, since I was 19 years old, I was making six figures in this job. I worked for good departments. I paid really well, and I could work a lot. So since I was very early on, I was like, this is amazing. I'm a millionaire. I can buy whatever I want and everything else, but it came at a huge cost. So that's something that you want to talk to the recruits about and just meter themselves from the beginning.
I'll just say one sentence. I think we need to teach people also the difference between decompression, suppression, and escapism behavior, like avoidant behavior. So they're consciously decompressing or off-gassing or, figuring out what to do with the content of the day rather than just hope it dissipates or just throw it, reinforce the shelving that, all these boxes are in.
So you touched on a term there that's been said a couple of times throughout the conversation this morning, and I think it's important to point it out, and that term was resiliency, and it's become a more commonly used term, a popular term, especially in the context of first responders. So we use it an awful lot, but not very many of us know really what it is or how we get to it. How do you become more resilient? So I think that we need to ensure that when we're working with the first responder population, we're very clearly articulating what resiliency means and exactly what they need to do to become more resilient, because it's a concept. It's not something you can take a class and then boom, you're more resilient. There's things you have to do over the course of your career, over the course of your life, that you have to continually practice. You have to institutionalize those practices within your everyday life in order to become more resilient. And so there are, some really good resiliency curriculums out there that you can can grab and pull off the shelf and use with first responders that are first responder specific. The one that we have been using lately that is wonderful is the Struggle Well program, which really seems to resonate with first responders. And it's very concrete. It's very operationalized. It's very specific as to the steps that you need to take and what you need to do daily, weekly, monthly, yearly, et cetera, in your life to reach that resiliency. Their program is based on the science of post-traumatic growth, which is a little bit different than resiliency, but just the fact that it is very concrete and operationalized and is a plan to get resilient, I think, is what is important.
We have time for one more question, and then I'm going to ask if we can, maybe one, max two of you answer whatever this question is, because I want the folks to hear from you.
I'm not really asking a question. I'm just going to make a little bit of a point for y'all. First off, if I went to my fiance who has 23 years in law enforcement and said to him that he needs to practice self-care, he would look at me like I had 5 eyeballs. So, and I know it's just a word and stuff like that, but calling it self-care, he just, no. Another thing is, in speaking of the culture, we recently, first off, I was one of the inaugural class of the First Responder Project. I actually went as a supporter, and it was one of the most amazing weekends that I've had with my fiance because it actually taught me. We were originally called First Supporters as a spouse of a first responder, but we changed our name to be First Absorbers because we absorb a lot of what they will come home with. And the thing that it taught me, I just wanted to say about the First Responder Project, is to really put myself where my Leo is. And the example I was talking to Tracy last night was we were at a wedding over the weekend and I was getting angry with him because he wasn't in the wedding. He was sitting outside of the barn around the bonfire, of course, with another Leo because they tend to congregate together. And he was like, don't you remember what you learned about me about the First Responder Project is that when I go into restaurants or I go into big crowds, I'm immediately looking for the space that I have my back to the wall. So I know that I'm safe and I cannot access the level of joy that you are accessing when you're being social. So just learning that as a spouse has been incredibly helpful, like in our communication, but talking about the culture. There was a law enforcement officer that unfortunately took his own life about 5 years ago that was very close to my fiance, and he sent a text to his spouse saying that he was thinking about taking his own life. What my fiance said, which is what gave me some insight into the culture, was that the minute that his friend and colleague sent that text saying that he was thinking of hurting himself, that he might as well go ahead and do it, because then that means that they've lost all the trust within the department to come forward and say that this person was struggling, and he ended up successfully, I'm sorry, I know the verbiage, but taking his own life, which, but just thinking about the culture, the First Responder Project has done, it's basically, it's the reason why I'm still engaged. Sorry, thank you.
Great job. Brandon, we're going to start with you. What's a key message you want to leave with this audience?
So I'll say this. Quick plug for the First Responder Project's forgive me, retreats. We actually met there. I met your fiance and formed some really good lasting relationships that became much of the foundation of the work that I'm doing here tomorrow. So I'm a huge advocate for those programs. I would say this: if you get the chance, go to Washington, D.C. if you haven't been there already. Look at all the memorials. Look at the World War II memorial. That was my grandfather's memorial. Look at the Vietnam Wall, a very imposing monument. That was my father's memorial. I got a chance to go to the law enforcement memorial while I was there. What's different about this memorial is that it is unfinished. There is much space on the walls for the names that will be added in the future for law enforcement officers who die in the line of duty. Dr. Amanowski pointed out quite correctly earlier that we lose more officers to suicide than we lose in the line of duty. Their names will never go on that wall. They will not be honored. They will not have a nice funeral. They won't get space on the wall. They won't be seen as someone who made the ultimate sacrifice for their people, for their country, and for their communities. They'll be forgotten. They'll be swept under the rug. They'll be perhaps a cautionary tale, but they won't be honored on that wall. Think about that when you go back. If my initial mission was to keep names off of that wall, as it was by teaching officers to survive violent encounters on the street, I can only think that I failed because I didn't address the mental health issues that I knew were prevalent and knew were there. But we don't have to fail forward. We can start now. We can start preparing people for the things that they will face on the streets, help them understand the reality. You will have critical incidents. You very likely will experience these emotions, these traumas, and how we deal with them going forward. So please, if you're in any capacity to do that for a first responder or for first responders systemically, please do that. It is what we need going forward to make a lasting change.
So the thing I would kind of leave with is that you heard about a lot of different things going on, different programs, but the best part of this type of work is the community. So we've talked about first responder community, those supporting the first responder community. All of our programs have referred to each other, worked with each other, given out resources to programs in other states and other countries. We're not here to hoard this information. We're here to give it out, to help people become competent to work in this area, to support our first responders. And so reach out if you have any interest, because I know the panel up here is happy to give away resources, to collaborate, to help. So reach out.
I would say casseroles, handshakes, and donations. So think about your first responders. You never know when you're going to need them, and you want them to be healthy and happy and have a good quality of life when they show up for you and your loved ones. I think that first responders, because they're so humble, they are okay kind of being in the shadows. So I encourage you to lean in and find them. If you bring a casserole to a fire station, they'll just eat it as they're walking in. If you bring it to a police station, they're going to send a robot out, make sure it's not a bomb. Probably have the boot taste test it first. But I would encourage you to go up and shake the hands of first responders. If you see them grabbing food in Publix, or you have an opportunity to pay for them because they're in line behind you at the drive-in or the drive-through. But let them know that you appreciate what they do, and they're going to feel awkward about that and not know what to say back to you. But if you simply say, "I appreciate what you sacrifice for us," it goes a very long way in terms of humanity and connecting. It makes me emotional. So, and really put some sweat equity or financial equity into nonprofits and organizations that do that. If you can't show up and volunteer, and you're heart operated, we don't look for ego operated and coin operated people. We want heart operated people to show up. So offer to show up, or donate to organizations that support it, and we'll grow even more.
Thank you. I'll talk way too much today, so I'll try to keep it short. But listen, we're the audience here is for the most part providing clinicians, providing support for mental health community. So all I would ask you is this, and David touched on it, is with this community, you usually just get one shot. We definitely need good, culturally competent clinicians. But if you decide you're going to take that role, and both up here, Second Alarm, UCF for Stores, they have amazing culturally competent courses and all that you can take. And there's others out there, but they have an amazing ones. But if you're going to fulfill that role, just keep in mind what you're signing up for. When a first responder comes to you, they're going to give you one shot. If you mess that up with them, they're not going to go find another clinician. They're done. And what happens there is they're going to be by themselves by the fire, or maybe with somebody else, but the likelihood is going to be by themselves by the fire. And they literally in their minds would rather hurt themselves than go find other help. And that's why we end up on the news, or it ends up with the tragedies, because like I said, we're not going to shop around. It's just, that's the way it works. And I wanted to just say one thing, if I can, more about retirees, because it was mentioned up here a couple of times. And for most people, they have no idea what we're talking about, because they're like, retirees, you get a paycheck every month, you're done with a job, it's amazing. Well, here's what happens. You carry this burden your whole career, right? And you have these responsibilities. I mean, I had a patrol car outside my house. Actually, I had an unmarked for most of my career outside my house. People will still come and knock for things. And I'll be like, I'm off. I'm not working right now. I'll put a sign outside that says not working. But even when I hit the car, they still knew. The neighbors knew and everything else. And I was always on duty, basically. Anywhere I went, I was on duty. If I was in my county, I was on duty, right? So all of a sudden, I go and turn in all my uniforms. I turn in my badge and everything else, and every fire station, every police department is secure with badges, right? So next thing you know, you're being escorted to the place that you worked there for so many years. They tell you, peace out, have a great day, and I'll send you a check next month. That's it. And your network and everything else kind of goes away. So that's what the retirees in this business deal with, that all of a sudden they go from this weight on your shoulders to nothing. And you're like, oh, what do I do now? So keep that in mind, because for most people, retirement is like amazing. For us, it's kind of weird.
Very weird. I think what I would say is, as you, whoever you know, and I'm sure this is true for everyone, but something I learned early on in my career is that you have to ask that question. When you see somebody who's struggling, when you see somebody who's had a change, it seems like it's the hardest question in the world, but you're all part of the support system. The community is a huge part of our first responder support system. Every time someone comes up and says, thank you for your service, it just thrills me to death. I can remember the day of the Dallas shooting where 5 officers were killed in the line of duty. I came to Orlando for an event, and on our way back, we stopped at a restaurant, and just about everyone in the restaurant stood up and thanked us. And that was an amazing thing. When you know first responders and you start to see changes, you have to ask that question. Are you thinking of hurting yourself? It's the hardest question in the world to do, but you might just save their life. So community support is huge. Please be there for whoever you know that's in the first responder field, especially dispatchers, who are many times forgotten. I'm also the parent of a dispatcher now, so keep them in your thoughts, and offer to pray for them if that's your field, but definitely thank them for their service.
It's awesome. Bring it home, Kelly.
Thank you. So Doc did such a wonderful job this morning in our keynote, and one of the biggest takeaways for me that he spoke about that I think is very relevant here is the systems change approach and the systems of care, and how we really need to change the whole approach, the whole system of care, in order to truly make a difference. And that type of initiative isn't done by one agency or one person or one group. It takes a collective impact approach to shift an entire system. So we all can have a role, we all can have a part. As Dr. Rosick was saying, it's not proprietary. It's nothing that we own or that we want to keep to ourselves. It's something that the more we can share it and the more we can bring others on board to be able to do this important work, that's how we're going to make steps in the right direction and move that needle, so that way we're not losing so many first responders, and not just to suicide, but all of the poor quality of life that leads up to something like a suicidal thought. So really just keeping in mind that a systems change is what we need in order to move that needle.
Ladies and gentlemen, please join me in thanking Kelly, Meg, Luis, Tracy, David, and Brandon. One, for your service, and certainly for sharing with us how we can serve better. Thank you.